still recording?
I had to push the button.
Okay,
It's
good.
recording now.
Okay. All right, so let's look at a picture of this growth plate so you can see what I'm talking about. This is the epiphysis of the bone out here. And this region of hyaline cartilage right here is normal. If you looked at hyaline cartilage anywhere in the body, you know, on your voice box, on your trachea, on your nose, on your ribs, on the ends of the long bone, anywhere you look, it looks like this. It's normal hyaline cartilage, closer to the end of the bone. This is where the business of growth is happening right here. So if I were to describe the anatomy of hyaline cartilage, I don't use the cells to do that, right? Cells, matrix, and fibers, right? I talk about the matrix because the cells are spread out. There's one here, and one there, and one there, and there. They're spread out. Most of the mass here is matrix. What about this area right here? You see how that's changed? So in a growing epiphyseal plate, the chondroblasts and chondrocytes do some unusual things. And you can see what's happening here. These cartilage-producing cells are lining up in rows, in columns. And there are more of them per square area, right? So if I squared off this area right here and I compared how many cartilage-producing cells there are compared to that square area, you can see I've got 3 in this one, and I've got 1, 2, 3, 4, 5, 6, 7, 8, 9. You follow me? There are a lot more cartilage-producing cells per area. They're undergoing mitosis, but why is that important for growth? Because the matrix is being made by the cell. And so where you have more cells, you will have more matrix. You see how that follows? So what is long bone growth really? Long bone growth is actually hyaline cartilage matrix. Exactly. As soon as this primary ossification center catches these cells and it reaches the bone of the secondary ossification center, there will be no more growth. So what is long bone growth then? Is it actually bone that's growing? It's hyaline cartilage. Yeah, it's an increasing amount of matrix. And as long as you can increase, more matrix here in the growth plate. Now, you see why this would be important in a fracture. So a teenager that has epiphyseal plates all over them that look like this, if you make a fracture and the fracture is here, I'm not as worried. If the fracture is here, I'm not as worried. But if the fracture is through here, you see why you would worry about that? Because the bone is not going to grow as much as it should if you've damaged this area where these mitotic chondrocytes are producing matrix. Okay, so it's a really important spot. All right, questions about bone growth for me? Everybody's good? All right. What else do bones do? Now, this is a story I'm going to tell a little bit today and a lot more in the spring. So you're going to see this slide twice. Today, you're going to see it again in January. So what this picture tells you, your book tells you this, that bones are a major storehouse for calcium. And that is true. So let's learn the dogma. Here's the dogma. Osteoblasts will store calcium in bone in response to a thyroid hormone called calcitonin. So as our calcium levels increase, the thyroid gland makes calcitonin, and it causes the bones to store that extra calcium. On the other hand, when calcium levels are low, the parathyroid gland releases parathyroid hormone, activating osteoclasts, these are bone resorbing cells, to cause the bone to break down and release calcium in the circulation. So the first impression students get when they learn bone out of any A&P textbook is a lot of calcium builds bones. Calcitonin does this. Not enough calcium in diet causes parathyroid hormones to tear bones down. And so students learn this. I've seen it year after year. They learn Calcitonin builds bones, parathyroid tear them down. Calcitonin builds, parathyroid tears it down. You see the dogma? Here's the problem with that. Your mom goes in her mid-50s, to get a bone density test. And they discover that she is in the pre-osteoporotic condition. She is starting to lose bone density. She is entered and just passed her menopause. The estradiol is no longer supporting some of the bone-producing cells. Her bones are beginning to become porous. And the physician gives your mom an injection of parathyroid hormone. And the student texts me, the crazy doctor just gave my mom a shot of parathyroid hormone, and you told me that parathyroid hormone does what to the bones? Tears it down. So I have a problem with the textbook presentation here. I have a problem because if you don't tell students a little bit more of the story, now we don't have time to do the whole story today, but if you don't get a little bit more of this story, you have been misinformed. There's got to be a reason for that. Okay, so in the spring, you will learn that parathyroid hormone actually has multiple ways of helping increase blood calcium levels. It will include the function of the digestive tract, the liver, and the kidney. So this is a multi-pronged impact that parathyroid hormone has. In fact, the major job of parathyroid hormone is to add a hydroxyl group to vitamin D, making it active. So that's fair for me to ask you. The major job of parathyroid hormone is to make vitamin D active. Now, the milk that we drink is fortified with vitamin D. And you think, well, drinking milk is good for your bones, right? We learn this from kids. You know, even as children, we learn you would drink your milk, and you want the milk that's had the fortification with the vitamin D in it. Because milk has a very high level of calcium in it, and it has a very high level of vitamin D when it's fortified, right? So this is bone building, vitamin D. Yeah, that's true, but here's the problem. You must make that vitamin D molecule active, and you need 2 glands to do that. Parathyroid hormone finishes that process. It actually causes the last hydroxylation step to make vitamin D active. And if you don't activate the vitamin D, it will not support the absorption of calcium in your intestine. So, mom got injection of PTH. What did the doctor really just do? The physician intended to increase now the levels of active vitamin D in her system so that she can absorb that vitamin D through her intestinal wall. So what's going to come with the injection? What's she put in her mouth? You're going to give her some vitamin D pills to take, yeah? What else you going to put in her mouth? Calcium. Yeah. So calcium pills. So get the calcium levels up. It doesn't help to elevate the calcium levels if you cannot absorb it. And vitamin D is the absorption molecule. PTH does that. So you see why? This is not really the whole story. The PTH injection does work. It would be better for you to remember that PTH elevates blood calcium levels. The condition that we have on the board here is the condition where you don't have enough calcium in your diet. So if you've got a poor diet with calcium levels, and you have no calcium, you have bad calcium supplies, okay, now PTH is going to do some damage. But normally, PTH is actually good for your bones. You see the difference? Does everybody understand that? It's not in your book. You'll get the details of the liver, kidney, and intestine all tied together in the spring. Yes?
Okay, so the parathyroid hormone, that has to make vitamin D active?
It makes vitamin D active.
Okay.
Yep. Okay. Now, the skull, the fetal skull, and I'll shut up. So, the fetal skull is unique because the bones are not fused together. So you learn sutural joints. in the lab, right? Help me. The frontal bone is connected to the parietal bone by what suture? Coronal. The two parietal bones are connected to each other by way of the sagittal. The parietal is connected to the occipital by way of the lambdoid. The parietals are connected to the temporal by way of the squamous. Good. So those are sutural joints. And in the adult skull, actually after 3 years of life, they should all be sutural joints now. But in the child's head, the joints between the skull bones are the remnants of that fibrous connective tissue. They're not hard yet. And so this labels the squamous suture. Really, it's not a sutural joint yet, is it? It's going to be. Okay? So in places where these soft places are here, joining what will become sutural joints in the skull, in places the fibrous connective tissue expands into a wider, soft place on the skull. And if you find one of those on a child's skull and you touch it gently, you can feel their pulse there. It is a highly vascularized tissue. And so this is where the name fontanelle came from. So the anatomist describes these as an anterior fontanelle. It is the last one to close. It's the one that most people know about, because most people have touched the baby's head here. What most people don't know is that there are 5 more on the fetal skull. So there's one here called the anterior fontanelle, where the coronal suture meets the sagittal, the soft place. It's supposed to close before the child turns 3. The others close a little earlier normally. This one is called the anterolateral fontanelle. And I always have to force myself to say that, because I didn't learn it as the anterolateral fontanelle when I learned it. I learned it as the sphenoid fontanelle. Do you see why we call it the sphenoid? It sits right on top of the sphenoid bone. But this is a better name, y'all. You describe things in anatomy where they are. That's a better way to say it. Anterolateral. That's where it is, the anterolateral fontanelle. It's connected by way of what will be the squamous suture between the parietal and temporal bones to what we call the posterior lateral fontanelle. And in that posterior lateral fontanelle, I learned that one. Anybody want to guess? It's not labeled here. Occipital, that'd be a good guess. What? Occipitomastoid. Yeah, in fact, some anatomists call it that. I learned it as the mastoid fontanelle. So everybody can find the mastoid process. So you impress your aunts and uncles and people with babies, right? They're going to say, soft spot, what is that? You describe this to them. I'm about to finish that story. When you say, there are some others. Okay, so you may have a little trouble finding this one. You shouldn't, but you might. But this one has an anatomical landmark. That knot behind your ear is the mastoid process. And so from the mastoid process, you can work your way just slightly superior and posterior. Just move just a little bit back and up, and you can feel the soft place in their head right there. The mastoid, better term, posterior lateral fontanelle. Then working from that one, on either side, there's 2 of these, right? One on the right, one on the left. You work your way up to the posterior fontanelle, which sits at the junction of the lambdoid and sagittal sutures. Now, why are they here? I had a young lady, I tell the story every year, help students remember. She sat right here. Her name, when she was here, was Karen Reed. She married a young man named Shan Collins. They got married, they lived in a married student house, and he did Caleb Funderburg's job for a while here before they moved off. Sweet little girl. I'm teaching this, and I say to the students, I say, go to the nursery in the hospital and look at the new babies through the window. And you can tell immediately which babies were born by a cesarean and which babies were born vaginally. The reason is the babies that were born vaginally had to pass through a hole that was about 10 centimeters wide. Most human heads are bigger than that. Childbirth is all about the head. Once the head is through, it's over. The shoulders come through easily. Then the placenta comes. It's the head, getting the head out. That's the big job. So as the head pushes through the birth canal, it has to be squeezed. And when it gets squeezed, these fontanelles provide squeezability for the child's head. And after the baby's born, everybody's handling this baby so gently and tenderly. I always, we were that way too as parents. But I went and both my kids were born in emergency situations. I go in the nursery, and they're just flipping them around and stuff, and I'll say, dude, this is a human. You should be gentle with the baby. But they're tough little boogers. They come through, and they get in the nursery, and they have cone heads because their heads have been squeezed coming through the birth canal. And it's a major problem if the fontanelles were to seal up and suture before they were born. This girl sitting here, Karen, she said, after I was born, my anterior fontanelle and sagittal and coronal fontanelles here sealed too quickly. And what I'm about to tell you was an issue. In addition to providing some room for the child to be born here, to make their heads cone-shaped, in addition to that, these soft places allow for growth of the material inside the cranium. Never again in your life will the brain mass increase as quickly as it does in the first 3 years of your life. And so without the room to grow, there's a problem. And so I said that, and she said, now I understand why. And so she said, my fontanelles closed too early, and they did surgery. She said, you want to see? And I said, yeah. So she bent her head over like this, and I looked at her head right here in front of the whole class. They took a Dremel saw when she was a baby, and they cut a T-shaped cut in her skull and opened her skull bones up when she was a child to allow for brain growth, and the scars were clearly visible still on the top of her head. You can look through her hair and see it. It illustrates for students what I'm saying here about the importance of these things. You've got to have them to be born, and you've got to have them so your brain can grow. They're important. All right. We'll start with the frontal bone. Wait.